Digital Media Classroom here at Wellington High School. Welcome to Dialogue with the Duke, sponsored by the Patricia Lindley Center for the Performing Arts and the Wellington Music Store located in downtown Wellington. I'm Bill Berger, your host, and this week we're going to continue talking about the Mind, Body, Spirit project. You remember last week we talked with Carol Burke. She is part of the Thrive project, and we talked about what Thrive was, how it is engaging in the Wellington community, and all the things having to do with Thrive itself. This week, we're going to be talking with Miss Debbie Kelly. She is from what's known as the RRN, or Rural Response Network, which is part of the three-pronged, shall we say, arm of the Mind, Body, Spirit project. So Debbie, welcome.
Hi, thank you for having me.
Oh, you're most welcome. As I said, we're going to be talking about the Rural Response Network. So I guess obviously the first thing we need to do is talk about the mission. What is the mission of the RRN, or Rural Response Network?
Well, the Rural Response Network is actually a consortium made up of many different partners. It's a grant program under the Lakota Way, sponsored by HRSA, which is a federal agency. And it is really just a group of residents from our service areas and other agencies that are working to reduce substance use disorder and increase the capacity of these communities to respond to individuals and families with this disorder and to get help and educate the communities.
Mm-hmm. Well, you obviously provide the perfect transition. Where do you actually work? What does the RN, where they focus their work?
Our work is really focused in the zip code areas of Wellington and Oberlin, and so the surrounding rural townships, villages, and then the city and village, and really well needed. All of the services, which you may or may not know, for substance use and mental health in our county are located in Elyria or Lorraine. Occasional satellite offices in like Amherst, Avon, but we have nothing in this area, so residents have to travel. We know that transportation can sometimes be an issue, so this was a really well-needed project to focus on this area and sort of build on the strengths of these communities and try to address some of the gaps that having no drug services available contributes to.
Well, the term rural is in the network, so to speak. Is this a lot like Thrive in that there's not that many people who know or what these services are? Has it been brought out to the community, or are we, by doing this dialogue with the Dukes, are we informing people for the first time?
Sort of both. So because this was a planning grant, a lot of the work that we've done so far was necessary but sort of administrative, I say. So we engaged collectively this group of people in a needs assessment, which we then have like a 40-page document saying this is how it's available, this is not what's available, these are the things that we can build on, this is what doesn't exist. We had to build a strategic plan from that and get that approved. So we're finally at the point where our action plan at the end of July was approved, and so now we can actually do some work, start building capacity. So you're one of our first.
Well, now you mentioned the 40-page document. Now, how many people are actually involved in that 40-page document? Is this something just within a few people, or again, is this broadcast wide?
The document is available wide, but we had the benefit of many, many people involved in that process. So the needs assessment, as I said, or alluded to, involved residents and people who live and work in these zip code areas in Wellington and Oberlin, also agencies that serve these communities. So we had folks help us do a stigma survey. We had, Main Street Wellington put it out, the police department put it on link. We had people sharing it within their parishes and congregations in both communities. We had all of the individuals, which we'll talk about, I'm sure, that are involved in this project as either a key member or via an MOU to carry out some of the action steps, all had a role. We met, a dozen of times in a big group of 40. So really, I think very comprehensive, and we have a better plan for it.
Well, again, you provided a perfect transition. You're being a very good interviewee. The MOU. People probably don't understand what an MOU is. MOU stands for Memorandum of Understanding. And part of the Memorandum of Understanding, or MOU, is the Lakota Way. And this was something that Carol and I brought up in the last segment. which had to do specifically with the Rural Response Network. So we talked about it a little bit, but Carol said that you and I would talk about the Licata Way. So let's talk about the Licata Way and how it is involved with this MOU.
Okay, so the Licata Way is a premier substance use service provider. They also provide some limited mental health services. They serve adults and teens, children, men and women. They have specialty services, and they do prevention, so it's sort of across the continuum. They are funded from all over the place, grants and private and state funding and through the Mars board. So they really are in a position to sort of know what's available in the community and respond to the needs. And so they're the ones who came up with the idea to write the grant for this project, recognize the lack of services in this area and sort of the difficulties with folks that they serve, getting to and from, and the support that's available out here. So their role is really instrumental in terms of administering the grant. So the MOU, they're really, I guess, what they would call the grantee. So then they're the ones that are working, through me. I coordinate this grant with them to bring on the other partners. Is it okay to talk about the MOU partners?
Go ahead.
So with an MOU is a formal relationship with this project. We have 8, including Licata. So there's Licata, Lorain County Public Health, the Mental Health Addiction and Recovery Services Board of Lorain County. We have the Road to Hope, Margot House, which is in Oberlin, that's a recovery housing provider. LINK, which is Local Initiative to Network Compassion. That is a project right here in Wellington that was developed among Chief Barfield and first responders and some area churches and others to help people get into treatment. They're involved. Oberlin Community Services, both Wellington and Oberlin Police Departments, and then Let's Get Real, which is a recovery support organization that is comprised of certified peer supporters, so people who have lived experience with substance use disorder. But I do not want to leave out, we have many, many more key members that are not formally part of it from MOU, but have been instrumental in the success of this project and continue to help with action steps and ushering things through. And those include the Wellington and Oberlin Public School Districts, both Wellington and Oberlin Public Libraries, Thrive Southern Lorain County, Liz through the Educational Services Center. We have Main Street Wellington and Oberlin Business Partnership. Salvation Army service units in both counties are involved. They're helping with some things, and with Mercy Health System, including the physician practices in both areas, and then Mercy Allen, the hospital, Oberlin College. So hopefully I've left off nobody, but everybody's important. But yeah, we've been very lucky.
Well, it sounds like there's a whole lot of people involved. So I would think that something like this would be more in the mainstream of what's actually going on, at least from a medical point of view. Is that correct?
You would think, actually, you would think, but so part of the, so I'm, thankful for this opportunity, and I'm glad that we came up with this project idea because I think it's going to help all of us. Thrive is also a consortium, basically, of a bunch of partners that are working in Southern Lorain County, and so it becomes, difficult when you have so many agencies that all have their own goals and their own responsibilities, and then we're all trying to work together. So I look at this as sort of an integrating. And it's really about, this part of this project is more about foundation and capacity. So what can we do to support the work that folks are already doing? How can we educate the communities about where the resources are? How can we make things easier, for residents to obtain if they need help, or to know where to go, because you don't know what you don't know until you need it. And so I think that there have been challenges, and like everybody else, we started during COVID. So it really started smack when nobody was anywhere except at home, and me personally was new to Licata, and to this project. So we've had a slow start, again, why we're so thankful now to really be able to start doing some things and get out there and carry out some of the plan.
Well, in addition to MOU, I've learned in the Air Force that it's all alphabet soup, and it's obviously alphabet soup within the RRN, Rural Response Network. If you could please explain the difference between SUD and what it is, and OUD.
Okay, so SUD is a term, it stands for substance use disorder, and it really encapsulates the whole degree of what we used to call abuse, drug abuse, or alcohol abuse, or addiction. Those terms are still used, but they changed it to substance use disorder. There's actually, I'm not gonna throw out more alphabets, but there's actually a diagnostic and statistical manual that physicians and trained behavioral health professionals use to diagnose substance use disorder. And so in that last version, they changed it to this broader category. So this really includes alcohol, drugs, any sort of drug, marijuana, any sort of, from misuse all the way through physical dependence and addiction. The term OUD stands for opioid use disorder, which is sort of a subset. So if you have read the paper, watched the news, you know that we have a huge public health crisis with opioids. Opioids includes both the prescription opioids like pain relievers and narcotics, as well as synthetic opioids like fentanyl. So that is the term for that. And so the primary focus of this grant from the top down was to reduce the sort of overdoses, fatalities, and the problems from opioid use, but recognizing that that doesn't happen by itself often, so in a broader vacuum with other mental health issues and other substance use. So that is the difference between those two terms.
Okay. Before we go to break, I want to do one more thing, and that is go over the specific goals of the Rural Response Network, if you could enumerate them.
Sure. So we have really 4 primary goals. One is around access. So I said that there are not services directly in Oberlin or Wellington communities. So we're trying to find ways to increase access. The police department in Wellington, I mentioned Link. Anybody can go to the police department anytime and ask for help. They don't have to fear reprisal or arrest if they have outstanding warrants, and then they link them with Let's Get Real, peer supporters, another of our members. This was here before us, but Rural Response Network is trying to also create that at Oberlin Police Department, that same program. We're also looking at telehealth. If there was one good thing about COVID, it's that people got used to interacting over virtual platforms with medical professions. So we're trying to increase telehealth capacity in areas like Wellington LCC Center, also a partner. And then the final thing would be recovery support meetings around access in our communities. There are only pre-COVID like 5 meetings, 4 AA and 1 Narcotics Anonymous. So we were trying to offer different alternatives and additional just capacity. Second was stigma and increasing education. Stigma are negative perceptions about people that have a certain condition. We did do surveys, so we know that that exists. It exists in the community, it exists among first responders, health professionals, so we want to really educate. Substance use disorder is a brain illness, like anything else. It's just that the brain is the organ that's affected, so we have a whole series of trainings that we're going to be doing with the general public and community, as well as some specific groups. The third measure is increasing the safety and security and disposal of prescription medicines. Many people start a substance use disorder in their own medicine cabinet or their families. So we have medication safety locking bags. We have disposal pouches that are safe for the environment and also negate the effectiveness of those medications so that somebody can't divert them and use them in a misappropriate way. And we also have fentanyl test strips, so to prevent overdose deaths that we are going to be giving out. And then finally, well, that was our final one. So those 4 goals are what we're focusing on right now.
Well, we'll take a break now. We have obviously talked about the Rural Response Network and what it's all about, its mission, its goals, and so on. And when we come back after this message, we'll be talking about specific data within the areas of Wellington and Oberlin. This is Dialogue with the Dukes. hope that when you need a haircut or just a trim, shall we say, we hope that you'll visit the Colonial Barbershop located in downtown Wellington. We are talking with Ms. Debbie Kelly. She is the person responsible for the Rural Response Network in both Oberlin and Wellington. And we kind of talked before about what the mission is, the goals and things like that. But now I really want to get into the meaty part of it, shall we say, the actual data that's been taking place all the way from 2018 through actually August of this year, 2021, I believe that's correct, Debbie. And talk about the specific things having to do both from a negative point of view and from a positive point of view. So Debbie, two things have come out. The fact that there were 43 overdoses occurring in the area from 2018 through August of 2021, the third quarter. And also there were 163 overdoses by residents. So there seems to be a difference of about, 120 overdoses. What is the difference between those particular numbers?
Sure, I'm glad you asked. So we have, across the county, these initiatives have already existed. There are software programs, and the first number that Bill mentioned, the 43, comes from OD Maps. We have two different softwares that our police, fire, first responders, drug task force use. One is OD Maps, one is New World. I didn't even report that one. So we have a current initiative that the health department got a grant, and they're trying to do like an interface to bring more responders on OD Maps. So that is where that came from. There may or may not be overlap with 163, but we know that it's not for sure. And so the second number, the 163 overdoses by residents, comes from our hospitals within our county and outside, because it goes by zip code of the resident, and then they report. So we know that of individuals who lived in the 44074 or 44090, 163 were seen in a hospital emergency room for an overdose. Most of those were non-fatal, because if they're fatal, they get transported to the coroner, medical examiner's office. So we use both of these numbers when we talk about overdoses, and we just try to clarify and know that we are working on getting a more streamlined number. But I think that it tells you there's a lot. What we do know, I was just in a meeting the other day where traffic fatalities in Lorain County are almost double this year than they were the previous year, and I want to say, don't quote me, but they're like 28. So just to put it in perspective, I mean, our county last year had 138 fatal overdoses that we know of. So it is a big problem, and one thing that I'd like to clarify, when we first started this project, I think there was sort of a perception that this grant project was because we had like a huge number of overdoses in this rural area, and that is not the purpose of the grant. Certainly Oberlin and Wellington are not unaffected. Proportionate to their size in the county, substance use disorder is impacting just as many families here as around. These numbers are nothing like what we see in Lorain and Lorain and Elyria. Of course, the grant was really to address as I said, the lack of services in this area, the fact that when you live in smaller communities, there are some strengths, and then sometimes there are challenges. So the fact that a lot of people know each other or know your family, makes it harder because of stigma or feelings for some people to reach out in their community or to know where to ask for help. So, things like that. People tend to get their information differently in rural communities. They don't necessarily read the morning journal. They have different newspapers, they have different websites they go to, so it was a matter of trying to get information on those things. So I do just want to clarify that in context of these numbers. So I hope that explained a little bit more clearly when I saw the number that you provided for me, 163 overdoses, now granted that's over a 3-year period, but I look at Wellington, we've got about 5,000 residents or so, and I don't know how many. About 14,000.
Okay, so we'll say 19, 20,000. Now 163 doesn't sound like a whole lot, but especially when you start talking about the number of fatal overdoses that there are, and especially when you talk about fentanyl, the fact that we see on the news all the time, that synthetic drug can kill worse than anything else having to do with overdoses or anything like that. So 163 may not sound like many when you're talking 19,000 people, but on the other hand, that's like 163 too many.
Yes.
But something like that. Well, another survey that came out, and this was in 2018, so this was like 3 years ago, it was called the Pride Student Summary. And it said that 6% of the people in the senior class, both, I assume both Oberlin and Wellington, they reported that the fact that they had used drugs not prescribed for them, and you talked about going to the medicine cabinet, that 6% kind of bothered me, but didn't surprise me. But the one that really did surprise me was that 2% of 10th graders said that they are also going into the medicine cabinet. How does that relate to the Rural Response Network, and is that a lot, or do you think?
So, the Pride Student Survey Wellington participates in, and last year, or in 18, 6th, 8th, 10th, and 12th students, 12th grade students are surveyed. Mm-hmm. And there's a whole lot of questions about behavioral health, health and fitness, substance use disorder, family that are asked. This one, because it's about prescription misuse, and we know there's a sense of underreporting too, but the jump from 2% to 6% was alarming to us, because that was the first time we had asked 12th graders in several years. I think the last time was in 2009 that 12th graders were included in the survey. But more, I think, I included it here because I thought it was relevant, because it's most of the prescriptions that are being misused are opioids or benzodiazepines like Xanax and anti-anxiety pills and Adderall. So all of those are addictive. All of them can cause problems, but it's important to us because of teenage years. So we all know, or we've all heard, that the brain doesn't fully develop until you're in your early 20s. So when you're talking about addiction as a brain disease, and you're learning things like problem solving and resilience and how to handle emotions, those same pathways in your brain are being affected by substances. And a lot of people, I think it's better now because there's been a lot of education in the last, because prescription medications come from a doctor, many people don't view them as something, dangerous or something that can cause addiction, and they can, and they do all the time. So prescription misuse, using more than is prescribed by your doctor, taking medication that's not prescribed for you, so those are two examples of misuse. But people do that, and even sometimes opioids are very strong, and so that even the natural opiates like the treatment OxyContin that they give you for cancer treatment, that's monitored and prescribed by a doctor, that's for a specific purpose under controlled conditions, still addictive. So doctors don't keep people on it if they don't have to, longer than they have to because of that nature. So we think that's important. We think all teen use is important. Even things that tend to be normalized in our communities like alcohol, even marijuana, because of that effect on your teenage brain. And the alarming statistic, and somebody just sent me a poster of it today, 90% of adults that have an addiction to any substance started using before age 18. So it doesn't mean if you use as a young person that you're going to develop an addiction, but of people that have addictions to something, they started. So working backwards, so it's that's a big statistic.
Yeah, it's
a big statistic.
Yeah, it certainly is. Well, there's a couple more data things here that I truthfully don't understand, because I had one idea in my mind, yet the data here says that first of all, there's no substance use disorder or opioid use disorder treatment services located within our area, and there's no formal screening or intervention. And yet I seem to remember, and you brought it up a little bit earlier, about the fact that the Wellington Police Department has a program where you could just knock on their door and come in and say, I have a problem, and there's no stigma attached or anything like that. There's no arrest warrants or anything like that brought up. So I don't understand, maybe this there's no substance use disorder or the opioid use disorder, the SUD or OUD treatment services, and no formal screening. So I don't understand why they say that, and yet we have these things also with the local churches involved, I believe.
Yes, I'm not sure how much the churches are involved now, but it's certainly a goal. Link is a partner, as I mentioned. That's a good question. The fact that there are not services would be to treat those disorders and provide support services to the family. Those are, as I said, primarily located in Lorraine and Elyria with a couple, there's like
Right.
some places, in some of the suburban areas. The access to treatment, the fact that you can walk in there and get help right away, is a wonderful thing. Again, as I said, trying to replicate it with Oberlin, and shore that up. And I should have brought you the number that are still going through Wellington Police Department, because we do have those stats. It didn't occur to me. But so that would be a way to get help. And just not what we typically talk about as the treatment, recovery, and support. That's what one of our goals is, access. So if I have a problem, where do I go? Like, do I just Google? Do I look in the phone book? Is there a place where I know that I can find resources? Or can I go to the police department and somebody will come and hook me up with what I need? So that is around access points, but not actually services. So somebody will come and get them. They will take them to a hospital. They will try to get them in detox. They will usher them through, a process, and I think that is an awesome thing. But it is different than screening. The people that are going there have a problem. So if you already know that you have a problem and you're at your wit's end, and thank God that they can go there 24/7, So, but they're not screening. They're just taking that person's word for it, and then the agency that they hook them up with is actually doing that assessment and screening process. So there is such a thing called screening, brief intervention, and referral to treatment that is generally in either non-traditional places, like say Salvation Army, or a food, pantry sort of setting, where people are going for other help. You can, where there's some sort of screening, you can kind of do like a 5-question survey that gets at substance use or mental health, and also in primary care, and that's where it originated from. So we are working with Mercy and, looking at that and some other things as well. But they're really, the fact that there are no actual services in these two areas is true. That is an access point.
So somebody walks into the Wellington Police Department and maybe he or she is in really, really bad shape. It's 3 o'clock in the morning. What do the police do? The person on call or whatever, what do they do? Who do they actually call if this person's really in bad shape?
Let's Get Real. So the police and the emergency rooms have a direct line that goes to Let's Get Real, which is the agency that's comprised of certified peer supporters.
Okay.
And then there's also another line that you can call directly. But they actually send a peer supporter out at 3 o'clock in the morning. They come, usually within an hour, and then they will get that person help, whether that's detox. Sometimes if there's not an opening, they're able to work with folks to get like a voucher for a hotel or something overnight. Sure. And keep them safe. They sit with them and talk with them, because they are all persons with lived experience. They're able to sort of, empathize and sort of cut through some of the stuff, that the people are feeling, I think, and, alleviate some of the anxiety and, so I think it's worked really well. It's been successful. They go to emergency rooms also. If somebody shows up in the emergency room, it's called a warm handoff program. They go there too, and they can help get that person into treatment, and they try to follow up, and So I think, again, though, those are about access points. So really fortunate to have that, and especially in Wellington. And you mentioned before the churches, Wellington was really cutting edge with this, So the Rural Response Network really strives to be what Link was sort of organically. And Link still exists. It is actually like a nonprofit organization now. So we're just with COVID, like everything else, people got diverted and where their attention went. And so we are working with Link to sort of, get that back to the robust level that it was before.
Well, and we already touched on it a little bit, but the last thing I want to talk about is the negative perception to use, or should I say abuse, of drugs. And I have to admit that before the Wellington Police opened up their station and said, hey, if you have a problem, come in, I never really thought of the use or abuse of drugs in anything but a negative way. And yet my eyes have been opened, and probably I should have been opened 10 years ago when I had my operation, and the opiates were prescribed for me for the pain and so on. I'm very glad, number one, that I didn't. In fact, I just tried to do my best to live through the pain, because I didn't want to get hooked on anything, but the fact that people do, and they're, whether it be an operation or whatever the circumstance, there are people who actually are prescribed certain drugs and things like that, and for lack of a better term, they get hooked on them. So how do you actually, and we talked about it a little bit, but I want you to amplify it, how do you actually shall we say, go against these negative perceptions and say, hey, sometimes it isn't their fault. Yes, it might be in many cases it may be their fault, but in many cases I think, personally, that it's not their fault, it's something that was prescribed for them and they just got addicted.
Right. Even with illicit drugs or alcohol, that same shame and stigma exists. So I think the biggest thing for people is, is thinking that people had the choice to take a drug, but that is different than becoming addicted. So I think addiction is, substance use disorder is a chronic medical condition, and when we talk with health leaders, which we do, it's interesting, we were looking at stats, something like a third maybe of American hospitals actually teach about addiction to physicians in med school. And so we just talked about that with Mercy Health leaders. And so I find that, I'm a certified or licensed chemical dependency counselor and a social worker by trade, even though I don't work directly with individuals.
Right.
And so when I think about that this is a medical condition, but we don't learn about it in medical school. So I think that contributes, and then the very symptoms of addiction kind of give credits to the bad rap. So when people are addicted, they lie and they're dishonest and they are consumed by their need for that substance, so they do a lot of things they wouldn't normally do. The way that you combat that is education about brain and disease of addiction. We have actually some trainings that we do on removing the shame and stigma of addiction. A lot of that is exposure, understanding that, the faces are not what you think about. They're CEOs of companies, they're police officers, they're nurses, they're doctors, they're moms, they're dads, they're students, their grandparents. Anybody can be hit by addiction and struggle and work on their recovery with that. So it's about exposure, it's about words. Words matter tremendously. I've corrected myself a couple times here because there are, sort of do's and don'ts. We don't talk about struggle with addiction. We don't, because we don't say people struggle with diabetes, and so that is a word that they, advise you don't use. So it's really, our approach is going to be around three things, sort of social media campaign and community education about words and how we talk about addiction, and substance use disorder. It will be around training about the disease of addiction and the impact of stigma and where stigma originates. So we actually are doing a training with Southern Lorraine County Ambulance District and the firepersons, what's the correct, on November 2nd during their training night. They're letting us come in and talk with them, and they're highly educated and they respond and they do a lot on their own, but we're going to be talking about that with them. So I think that, and then as I said, exposure. So there have been movements, there's something called Faces and Voices of Recovery. The Mars board did something with local people, but it's really about trying to encourage folks to stand up and sort of own it and talk so that people see that it's not them, it's all of us. And I think that's what's really, really important. So that is our goal. And hopefully you guys will be seeing here in Wellington and Oberlin, notices about some of those trainings. We're trying to do them all over the place and also virtual. And they're for anybody, so more to come.
Well, we'd like to thank Debbie Kelly for coming in today and talking about the Rural Response Network. And I'm hoping that anybody who might be viewing this particular segment of Dialogue with the Dukes and they think that they may have a problem or they do have a problem, maybe this will inform them about places that they can go, explaining about all these different things that are available to them. And it's not necessarily a bad thing, especially if you yourself recognize what the problem is, and I think you would agree with me there. If you recognize that you have a problem and that you know that there are places that you can go, and we hope that if you do see this particular segment of Dialogue with the Dukes, maybe we might save a life or two or three or more by having, not only seeing this particular segment, but also seeing what's involved with the Rural Response Network, part of the three-armed part of the Mind, Body, Spirit project. We'll be back again for the third arm of that, hopefully very soon. This has been Dialogue with the Dukes.